Hi, everyone. It's Leslie Mead, and I'll turn the call over to Katrina Casta to introduce our speaker today and introduce the topic.
Sounds good. Can everybody hear me?
Yes.
Yes.
Excellent. Good morning. Good afternoon. Hi, everyone. All right. Well, thank you so much. I'm really excited about this call today. A big thank you to Candace Robinson from Capital Impact Partners who connected us to Ann Tumlinson, who's our speaker today. She is the CEO of Ann Tumlinson Innovations and is going to be presenting today on Medicare Advantage and the opportunity for home care cooperatives. This is our first follow-up topic from the Home Care Conference. So we're really excited to dive into this a little bit more. Just quickly on Ann Tumlinson Innovations, they are a research and advisory services firm, changing how businesses, communities, and public programs serve older adults. And Ann, who is the CEO, is a nationally recognized expert in the economics of an aging society. She advises government officials, business leaders, and investors on innovations in financing and delivery of health and long-term care to older adults. I know she is widely and very much respected in this field and is a great resource for us. So thank you so much, Ann, for taking the time to present to us today. Just very quickly before we do get started, just a couple of housekeeping items. We will go through the presentation and we'll present. If everyone can put themselves on mute during the actual formal presentation, that would be helpful, just so we can make sure that we can hear her and there's not a lot of back noise. But then after the presentation is done, Ann is going to open it up for Q&A. So you can feel free to unmute yourself at that point and ask questions freely. It's a great opportunity to talk and ask questions and learn more. So please don't hesitate to do that. This is the only topic for today, and this is being recorded, so this will be available on seniors.coop following today's call in case you want to revisit the presentation or share it with others. So with that, I think I will turn it over to Ann to begin the presentation. Thank you.
Great. Thanks so much. Thank you for having me and for the introduction. I'm excited to be able to talk to you today about all of the changes that are happening in Medicare that relate to the services and supports that you all provide. So that's what we're going to be doing today. We're going to be talking about this piece of legislation that Congress passed this past year called the Chronic Care Act. And it really represents, at least right now, very symbolically, a pretty big shift in the way that the federal government thinks about this health insurance program for older adults. And so we'll be talking today about that. I'm not in control of my slides, so I'll just ask if we could advance to the next slide. I think that, there we go, great. So, all right, so here's what's going on in a nutshell. There are new, and I'm going to explain all of this in more detail in a few minutes, but just at a high level, just so you know what we're going to be focusing on in this presentation, there are new federal rules that now allow private insurance companies that are offering Medicare plans additional flexibility that they had not had in the past to actually also offer, in addition to the healthcare benefits they offer, to also offer certain types of long-term services and supports, such as home care, home-based care, as what are called, it's something that they call supplemental benefits. And they can even target these benefits to certain enrollees. So these two things, that for these benefits and to target them just to particularly frail, for example, older adults, is a new rule in the Medicare program. And but what we see, so this is very exciting. This is a big change, but it's going to take, I think, a lot of time and effort on the part of both the insurers and organizations like yours to kind of come up what I think is a pretty steep learning curve in working together because, private insurance companies that have been largely paying for healthcare are not really familiar with the long-term care, long-term service and support space and home care, private pay or Medicaid or otherwise. This is new to them. They don't understand who you are and what you do and what the benefits are to them necessarily. And I've also found that long-term service and support providers, need some kind of basic education around the Medicare program and these plans as well. So this is a process. I think that we're at the very beginning stages where the insurance organizations and the long-term service and support providers are starting to learn a new language. So I think that my advice to anyone in your shoes right now is not to worry, first and foremost, that you've missed any kind of a boat because this is really, really new. There's only a small number of insurance companies who are doing this in the first year, but now is a really great time to begin educating yourself about the program, how these insurers think, and maybe even how you might over time engage with them around the service and support that you offer and what your value is. So with that, if we can go to the next slide, the next section is designed really just to give you some fundamental understanding of even what is Medicare and Medicare Advantage. So if you go to the next slide. Okay, so first of all, and I don't mean to be, really basic, and so for those of you who know this, just bear with me, but I think it can be confusing because Medicare is a federal health insurance program that is administered here in the Washington, D.C. area where I am, and it covers nearly everybody who is over the age of 65. So pretty much everybody who's paid into the payroll system, paid their payroll taxes over some period of time during their working years, turned 65, and then they are eligible for Medicare. It also covers certain people under age 65 who have disabilities through the disability insurance program, and then it also covers a few folks who have end-stage renal disease. So it's I think for your purposes, just kind of think of it as like if you have anybody on your service that you are serving right now who is over the age of 65, almost certainly they are getting all of their health care paid for through the Medicare program. And what it covers is just basic medical care, hospital, physician, post-acute care, durable medical equipment, outpatient services, so kind of like the range of things that you would think of as being part of any kind of health insurance program. With it also covers hospice care.
You've lost audio.
Yeah, okay, thank you. And is it just Ann that we've lost?
Oh, we lost me too.
No, me too. Me too.
Me too. But we can hear you, we just can't hear Ann.
Right.
Yeah.
Yes, exactly.
Yes. I don't see that she's still, and you're still connected.
Hello.
Muted.
Ann?
Hello?
Hello, everyone. Can you hear me? This is Ann.
Yes, now we can.
Ann, we lost you
I
for a
have
little bit.
no idea what happened. I just was talking, and then all of a sudden I'm talking about who Medicare is for, and I heard this beep, 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 and off I went into the ether. But I found the phone number, and I apologize. I have no idea what happened. So fingers crossed that doesn't happen again. All right, so if we go to the next slide.
And mute, let's go mute again except for Ann.
Yes, thank you. Sorry. Okay. So I just talked about how Medicare is the federal health insurance program that covers older adults and covers traditional health care benefits. And so, not to be confused with Medicaid, which is a program that some of you may have contracts with, which pays for home care and long-term care and nursing home care and that kind of thing. That's not covered by Medicare, typically. Right. So Medicare typically does not pay for assisted living or long-stay nursing home or private duty or personal care aids. Nothing that we kind of put in that long-term care bucket is covered by Medicare. So moving on to this, stay on the slide that we're on right now. Medicare is available to older adults and people with disabilities through two options. One option is what we kind of call original Medicare, traditional Medicare, Medicare fee-for-service. This just means that the federal government just pays directly for any healthcare services that the older adult uses that are part of the program. So you go to the hospital, you present your Medicare card, the hospital files a claim, it gets paid by Medicare directly. So this is federal government is literally paying that bill. Individuals in Medicare fee-for-service can also buy Part D coverage for prescription drugs, which is only offered through commercial insurance plans. And they can also purchase something called supplemental insurance or Medigap. Some of you may have heard of Medigap plans. And these cover the copayments and the deductibles and some things that are not covered by Medicare, like dental or preventive services. Okay, so that's Medicare fee-for-service. On the other side of the ledger, we have something called, and this is what we're going to be talking about for the rest of the program, is Medicare Advantage. So Medicare Advantage is a program through which private insurance companies actually contract with the federal government to offer commercial plans for Medicare beneficiaries so they can get all of their Medicare benefits through the Medicare Advantage plan. They kind of wrap everything up. They usually get their Part D prescription drugs from the same plan that they get their hospital and physician coverage from. And the federal government pays these private insurance companies what's called a premium or a per capita, and the private insurance companies are then responsible, for paying for all of the claims that happen from that plan. So if you go to the hospital and you have a Medicare Advantage plan, you present your, Blue Cross Blue Shield Advantage card, for example, and the hospital will actually bill Blue Cross Blue Shield and not the federal government, and they're on the hook. So the Blue Cross Blue Shield or Aetna or United or Humana, these are the big insurance companies that have a contract with the federal government to provide the Medicare program to people who choose to enroll in Medicare Advantage. So you might be asking yourself right now, why would somebody choose to get their Medicare benefits from a private insurance company when they could just have the federal government pay the bills directly? And if you go to the next slide, I'll explain the answer to that question. Great. So Medicare fee-for-service was enacted in the mid-60s, and in many respects, it really has not been updated since then. And what I mean by that is that there's pretty significant out-of-pocket cost requirements if you're in traditional Medicare, or original Medicare. So there's a Part A deductible, there is a Part B annual deductible, there's a Part B, and by the way, Part A and Part B refers to, Part A is what covers the hospital side and Part B is what covers physicians. So you also have to pay a premium in order to get access to the physician coverage under Part B. You also have a premium for your prescription drug coverage, and then you also have to pay a premium to supplemental insurance programs if you want to actually get relief from some of these out-of-pocket expenses. So one of the main reasons that people actually sign up for Medicare Advantage plans is because the federal government has kind of a deal with the Medicare Advantage plans, which is like, we're gonna let you make a small profit on each one of our beneficiaries that sign up with you. In exchange, you have to offer them a health insurance at a lower overall cost. So most Medicare Advantage plans are they have the opportunity essentially to kind of what we call buy down all of those deductibles and co-insurance amounts. kind of wrap it all up into one big program and charge a small premium and some deductibles and cost sharing, but they're really, for the most part, attempting to try to get all of this, offer all of this at an overall lower cost to the Medicare beneficiary. And the other kind of critical piece is that in Medicare fee-for-service, there's no cap on out-of-pocket costs. So if you're a really, really sick person and you're using a lot of hospital services, there comes a point where Medicare coverage ends and you're on the hook for catastrophic healthcare expenses. Medicare Advantage plans provide you with protection against catastrophic out-of-pocket costs. So this is the reason why people sign up for Medicare Advantage plans, is because it's less expensive than going out and buying supplemental insurance. So if we go to the next slide, there's another reason why many people, and we're getting to the part that's really important for you all to know. The other reason that people sign up for Medicare Advantage plans, and older adults, is because oftentimes Medicare Advantage plans, not always, and by the way, this is not uniform, it varies from one market to the next, but there are many things that the traditional or original Medicare program doesn't cover. It doesn't cover preventative care or dental or vision or, hearing aids, hearing exams. And many of the Medicare Advantage plans will actually offer some of these, and these are what we call supplemental benefits in Medicare Advantage. So they're required to cover preventative care by the federal government, but they might also choose to offer some small dental benefit or to offer eyeglasses or hearing exams or some, discount off of hearing aids. So these are the kinds of things that they offer. So what's changing, and the reason why we're having this call and I'm talking to you today is because the federal government has just said to the Medicare Advantage plans, if you would like, you can now cover some types of long-term services and supports as part of your supplemental benefit. A recognition that most Medicare beneficiaries, most older adults, don't actually have any kind of insurance to pay for home care or, for example, assisted living and or adult daycare, and so some of those types of services and supports can now be offered through the commercial insurance if they so choose. So we go to the next slide. All right, so the thing to know is that as a result of all of the cost-sharing protections, the out-of-pocket cost protections, and the supplemental benefits, and many Medicare beneficiaries really see literally an advantage in being enrolled. And so the Medicare Advantage enrollment has been growing really quickly, both in sheer numbers and as a percentage of the program. So we've got 22.6 million people now enrolled for 2019, which is a very big increase over 2018 and is also an increase as a percentage of the program. So we're getting close to having 40% of all Medicare beneficiaries enrolled in Medicare Advantage. This is, as you can see, if you look kind of down just in the last decade, an incredibly rapid growth in the use of Medicare Advantage to, as a way to get their health insurance. So really migrating kind of out of that traditional Medicare fee-for-service and into a commercial insurance plan in order to get access to that out-of-pocket cost protection and to the supplemental benefits. So we go to the next slide. All right, let's talk a little bit more about the new flexibility for supplemental benefits. If you go to the next slide, because this is a little bit, everyone just bear with me, it's a little bit, so we're technical or wonky, but it's important for you to know. So the way that the supplemental benefits used to work, so again, I'm referring to things like the dental, the vision, those kinds of extra benefits that Medicare Advantage plans might offer, is the federal rules said to the plans, look, under the old rules, you have to, if you're going to offer dental, you have to offer it to everyone. You can't just pick and choose. People with good teeth get dental and people with bad teeth don't. Everyone has to get the same supplemental benefit. Everyone who enrolls in your plan. Okay. So and also these supplemental benefits have to be primarily health related. So the federal rules were explicit in telling these commercial insurers that they could not, in fact, pay for anything that was sort of for the purpose of what they call daily maintenance. So this refers to, a support around activities of daily living, long-term service support. So the federal rules were really clear, and commercial insurance plans who are offering Medicare Advantage could not do this. So now under the new rules, and this is what's new in 2019 and going forward, is that Medicare Advantage plans are now allowed to target benefits to certain groups of enrollees who have certain clinical diagnoses. So you can imagine, and also it has broadened the definition of what it means to be primarily health related, recognizing that sometimes long-term services and supports really are directly related to the health and wellness of an individual enrolled in the plan. Getting support for ADLs, for example, can make a difference in your utilization of healthcare. So under the new rules, health plans are now allowed, as I mentioned before, to offer long-term services and supports and to target those to people who have certain clinical diagnoses. So, for example, you might choose individuals who have Alzheimer's disease. And now anyone in your plan who has Alzheimer's disease has access to, for example, home community-based services for a certain number of hours a week. I want to be really clear. This is not supplemental benefits are not a lot of money. Supplemental benefits is kind of like think of it as like the most of the Medicare benefit that the commercial insurers are covering is like a big cake. And at the very top, the supplemental benefits are like a little bit of icing on the top. So the reason why it's important is because it signals from the federal government, a willingness now to at least recognize that the work that many of you are doing and the people that you're serving and the way you're serving them has a really big impact on their overall health and well-being and the extent to which they use expensive healthcare services like hospitals. But it's not like the federal government is running out and, plunking down a blank check and saying, oh, okay, now we're going to have, a very generous program for paying for long-term care for everybody who needs it in the Medicare program. That is not at all what it is. So I think there's a lot of excitement about this when it first happened, and perhaps a little bit of misunderstanding about, at a practical level, just how significant is this? Well, it's significant in that it signals a change in the attitude, and I think the beginning of what I hope will be, a path towards integrating more and more of the types of services that organizations like yours provide into the Medicare program. If you go to the next slide. So just to give you a little bit more information about what the new benefits can include, the CMS or the federal government has been very clear that the new benefits, the long-term service supports, can include things like adult daycare, home-based palliative care, in-home supports and services, and support for caregivers of enrollees, as well as a variety of other things which I didn't list here. But these are kind of the key ones. And that they have to be recommended by a licensed professional as part of a care plan. That's a really important component of this, and that it has to kind of do one of the following things. It has to, be something that addresses the functional or psychological impacts of health conditions. So, you have diabetes, that's a health condition. There are functional and psychological impacts from that, and is this service part of the, overall treatment program to help address that? So these are the rules that the health insurance plans have to follow in order to offer the long-term services and supports as part of their new supplemental benefit package. So you go to the next slide. Okay, so there are a lot of challenges and opportunities associated with these rule changes, as you can imagine. Go to the next slide. We'll talk about those now. So first of all, CMS is the Center for Medicare and Medicaid Services, which is the federal agency that administers the Medicare program. This is, for all of the reasons that I've said before about private insurers, this is a really, CMS is used to, in the Medicare program, administering, a very traditional healthcare program. So they worry about, they want to they've loosened the rules a little bit, but they're worried about loosening them too much. And of course, in the process of that, sometimes they, they make it harder for the insurance companies to figure out how to administer this. But for the most part, what they really worry about, and I've got a long list here, and you can read these, and but they really worry about. So let's say a health plan offers home care benefits. Is the Medicare beneficiary going to understand what that means and be able to make wise choices between the different health insurance plans? Or is it going to create confusion, or perhaps give them a false sense of coverage? Oh my goodness, they're going to offer home care, I'm switching plans, and really it's only a few hours a week. Right? So they want to make sure that the health insurance plans are being very honest and clear and open in their marketing and not overselling, and allow for the consumers to continue to really evaluate and compare the plans accurately. That's one of the things that the federal government worries about. They also really worry about, and as do insurance companies, how are health insurers going to establish adequate networks? So when it's part of its pact, or kind of implicit contract with the public, the federal government has sort of promised Medicare beneficiaries, hey, if you get your Medicare benefits through this insurance company, then you have a right to have access to providers. In other words, the federal government wants to make sure that health insurance plans don't, say, for example, limit access to providers as a way of controlling costs. And so they worry a lot. If you're going to offer home care benefits, do you have enough providers in your network, in a network that your enrollees can access? And will they always be able to get the service that they've been promised, when they've been promised it? So these are the kinds of things the federal government worries about. And then on the insurance side, they've got just a whole host of challenges that they have to deal with. Like, for example, how do we figure out who should get this benefit? How do we target the population? Unfortunately, they have to target the population using chronic conditions because that's part of the federal government's rules. Well, you guys and I know that, qualification for home care is really related to function and functional impairment. So what insurance companies really should be doing is targeting people who have multiple functional limitations. But unfortunately, the federal government is not allowing them to do that. And even if they did, I don't know that they would know how. So, imagine you've got, 10,000, 20,000 people in a market enrolled in your Aetna, and you've got, tens of thousands of people enrolled in your health plan in a market, really trying to find the people who have certain, certain conditions and certain needs for long-term service and supports is it's a challenging thing for them to do. So, okay, if we go to the next slide. Okay, so I could talk more about the.
Hello, lost the audio.
We did too.
Yeah, we lost her again.
Just a second, we're going to see if we can get her back on.
Ah, what's happening?
We emailed her, the program's working for us, so Ann must be having a problem with her phone. Is she hung up?
Yeah.
So, hopefully she's calling back in again.
We did hear
Hello,
her.
everybody. I'm back
there she is.
on.
Hi, Ann.
I don't know.
Yeah.
I don't know why that happens. I would connect through my computer, but I'm worried that would just that would be is equally fraught. So anyway, well, anyway, yeah, exactly. All right, so I think I was getting ready to talk about the advice. I was going to just say we can talk more about what's challenging for insurers and CMS if you want to at the end, but I want to make sure to cover that we have time to cover the some of the research that I did with insurance companies. So again, you know, kind of keeping in mind that there are these large insurance companies that are going to be offering the new supplemental benefits potentially. I struck out to ask them, so, you know, what are you looking for from home and community-based service providers, home care providers who might be interested in contracting you? What's your advice for them if they want to engage with you? And so I got a list of kind of 10 things that I thought, you know, were good, you know, good pieces of advice. And so I wanted to kind of share those with you and go through them in a little bit of detail. And then I'll just touch on the data that we prepared at the end, and certainly welcome any questions on that. So one of the things that came out in the interviews that we did with insurance companies were that, you know, some of you may have already got kind of partnerships with healthcare providers like hospitals or physicians who are referring patients to you for, you know, necessary services to complement what they're doing. Or you may even be operating programs to help with things like transitions of care from the hospital home. You know, I don't know, any number of different kinds of programs. If you are doing that, one thing that can be a very powerful presentation is to approach the insurance company together with your healthcare provider, which is to say that you're offering, you know, a program in collaboration with them, and you know, it lends a lot of credibility to what you're doing, that you're already connected into or integrated into the healthcare system or with a healthcare provider. Many of you are small organizations, some of you are larger than others, and you may feel like, oh, I'm just a small organization. How on earth can I possibly, you know, contract with a big insurance company or even a small insurance company? And I guess I would just say what we heard from them was, look, you know, even the large organizations, large home care organizations don't have the capacity necessarily to help insurers meet the commitment to their members. So you can always position yourself as the backup, you know, so you can fill in where, say, for example, another organization might not have the capacity if there's more demand than the insurance company is expecting. One of the things that's really important, and I'm on number 3, around leveraging technology, is that insurance companies want to know, you know, so the worst thing that can happen from their perspective is that, you know, they're offering a benefit like home care. The member, the beneficiary, you know, calls up to get those services, and then they don't arrive. Or they arrive and the insurance company never has any verification of that visit. So they're definitely going to be looking for the capability of being able to verify that, you got the call, you're delivering the service, the person is in the home, and here's what's really valuable is to deliver information back to them about, any kinds of changing condition that you might be observing or risk for hospitalization. So that kind of information and being able to capture that and transmit it relatively easily is really important. One of the things that one of the insurers I talked to was adamant about was she said, a lot of times insurance companies don't really understand what you do, and they really are nervous. So, whatever you can do to reassure them that you have the ability to manage any kinds of service problems, that you have, any kind of quality programs that you have in place, training programs, key competencies around, for example, if you happen to have a program that's a dementia-related program, anything that you have that, documentation about your capabilities and competencies, that's going to be important to them, and being able to explain to them why what you are doing is different from what medical care offers and why it's important. So these, just don't expect them to necessarily know or understand that. You go to the next slide. Okay. So, so here's one that I think kind of gets overlooked a lot, which is that remember that everybody that you are serving is potentially one of their members or a potential member. And they're also the members for whom the insurance company actually gets paid the most. So we didn't talk about this very much, but insurance companies get different amounts of payment for different types of members depending on how sick they are. So you're really serving the population for whom they get kind of the most or the highest payment. And you're at the front line of that relationship. So they're looking for, insurance companies get measured on customer satisfaction and a wide variety of different kinds of quality measures, which you can actually find online at the website for the Centers for Medicaid and Medicare Services. So, you have the ability to improve their relationship with their members by being kind of an ambassador for them and reporting back to them where there are issues or challenges we talked about through the technology. So one of the things that they're also looking for, number 6, is, and I'll tell you what I mean by this, is they're looking, a lot of home care organizations or, organizations like yours that are offering, care transitions programs or things like that, or would say to the insurance company, hey, I think we can reduce your costs. If you use my service, we'll do care management, or we'll, deliver this service in the home, and we'll add value to your company, and by reducing, for example, the rate at which somebody has to go to the hospital. So lots of times insurance companies are very skeptical about that, and they would be interested in knowing, what proof do you have? Well, obviously, very few of you are probably equipped to actually do your own peer review, evaluation studies, and nobody really expects you to, but there are some of those in the literature to the extent that you're aware of them or know about them, bringing them to that conversation. If you have a Medicaid contract, that's great, because a lot of the organizations with whom you have a Medicaid contract are also offering Medicare Advantage plans. And so they already have a contract with you, and they might be interested in contracting with you on the Medicare supplemental benefits. Again, how do your services fit into, instead of just, hey, why don't you pay for 10 hours of home care a week? Maybe you can offer programs. Like, how about, a respite care program for family caregivers, or a transitional care program from hospital to home that the reason the insurance companies like those is because it limits their liability, but it still offers something really valuable. So it's not a lot of hours, but it is enough to offer something of value. Definitely have a conversation with insurance companies about what you do for caregivers. They're all looking for caregiver solutions, and it's going to be a rapidly changing area. So we're going to see new guidance from the federal government very soon. It's going to, I think, further impact these, the way the insurance companies are approaching these kinds of benefits in their market. And I will just say also that we've just received some data that indicates there really are just a very small number of health plans in the 2019 rate year who are actually offering these benefits. So just to put a finer point on it,
is it pica? No, it's just flavorful.
I think if
Can I get some white cheese?
Could you put your phone on mute? There we go. Good. So we're going into what's called the 2019 plan year, starting on January 1st. But the plans themselves are actually starting to prepare for the 2020 plan year, starting right away. So in other words, they're, if you're interested in doing this with a health plan or health insurance plan, you're going to be looking at the 2020 rate year as the opportunity. So meaning, they're going to do the enrollment for that year in October of this coming year. So in October of 2019 is when they'll start enrolling their new batch of enrollees for 2020. They're designing their benefits now for 2020. So you just want to be kind of aware of that timeline. Okay. The only other thing I wanted to say, and then we'll have 15 minutes to have a discussion and some questions, is that, you may remember that earlier that I mentioned that, health insurance plans and certainly the federal government are still somewhat focused on diseases. Identifying high-cost disease or chronic condition categories like CHF or chronic pulmonary disease. But what we know from the data is that actually it's people who have functional impairment, who have trouble with activities of daily living, who actually are the ones who are high cost. So if you advance the slides all the way to the slide 20, I'm going to skip over the other ones. We have to make sure we have time for questions. All that slide 20, and by the way, this data is yours to use. So feel free to use it in any conversations that you want. This was funded by a foundation and it's in the public domain now. But that Medicare spends more on people who have functional impairment. So again, you are taking care of the population that is highest paying and highest cost to the Medicare Advantage plans. It's not just about having chronic conditions, because if you have 3 or more chronic conditions and you don't have functional impairment or difficulty performing activities of daily living, your costs, your healthcare costs are only about $11,584 a year. If you have functional impairment, that is, challenges performing 1 or more activities of daily living, you're spending almost twice that or more than twice that on healthcare costs. So this includes hospitals, physicians. You use a lot of healthcare. You go to the emergency room a lot if you are living in the community and you have. And by the way, these are all people who live in the community, not people living in nursing homes. So these are, what I'm trying to say is that green bar to the far right with the per capita of 26,972, these are the people that you're serving the most, and they tend to also be the highest cost. So there's a lot of opportunity for, I think, and by the way, we're using this data in educating health plans as well to try to help them understand that it's not always about the underlying chronic condition that needs to be addressed. It's about the functional impairment, the need for supports and services in the home. So if you go to the next slide, I just wanted to flag for you some resources that if you're looking to kind of keep up with this, with what's happening in this space. There are several organizations that are tracking it pretty closely, and we've provided their websites. So there's a news organization and 2 trade associations, Homecare Association of America, and then the Better Medicare Alliance, which is a trade association here in DC for Medicare Advantage plans, and they're doing a lot of work analyzing the impact of all of these new changes. So let me stop there. We have 15 minutes and see how I can help you further. Let me open it up for questions.
Thank you so much, Anne. This is Katrina. I'll just jump in really quickly. That was very, very informative. Thank you. I feel like I finally actually understand what Medicare is. So that is exciting. I'll just, if you don't mind, just kick it off with a quick, simple question. Give people a second to gather their thoughts. I'm curious, how do co-ops figure out which Medicare Advantage plans in their area are going to offer LTSS benefits and sort of to which target group, so that they can really think about who to reach out to and what their competitive advantage might be? Do you have any suggestions?
Yeah, I do. And so if you go to the, so just as a quick point of background, I think one of the biggest challenges to your question about this is that the Medicare Advantage world is a little bit of a black box. It is hard to figure out, exactly what benefits plans are offering and where they're offering it, who they're contracting with, and all that kind of stuff. So we're lucky because the Better Medicare Alliance, which is one of the websites we have on this last page, has just done a report where they've hired Milliman, the actuarial firm, to analyze some of the federal databases to get more. So all of the health plans do have to report to the federal government what they're offering. And, kind of buried deep in those data files is a little bit more intelligence about, who's offering what and where. And so the Better Medicare Alliance contracted with the actuarial firm to do some analysis of that data, and they've just put a report out that's on their website that has a list of all of the health plans. So my recommendation is to pull that report down, take a look at the health plans. It's just a list of the plans and where they're located. But if you go to their website, so if you find the ones that happen to be in your market and you go to their websites and you look for what's called the evidence of coverage statement, you will find there, hopefully, some more details about what they're offering. So unfortunately, it's very labor intensive, but that's the only way I know of to do it. We are actually in the process of going through all of them and creating our own database, but we haven't finished that work yet. We've really just started.
That's great, though. Thank you. All right, other questions?
This is Kippy from Peninsula Homecare, and I do have a couple of questions. When we were going through the slides on page 12, I think I got the understanding that there has to be a physician's order for this for a condition that's treatable. I'm just wondering how this relates to just end-of-life care that's not hospice, that's not home health, but it's just support with activities of daily living at the end of life, because the end of life is not treatable.
Oh, that's a really good question, especially given that hospice, is normally, so, I'm sure as you know, when a Medicare beneficiary elects hospice, it effectively, for the most part, is provided outside of the Medicare Advantage plan. So Medicare Advantage plans are not responsible for hospice. If somebody elects hospice, they're no longer really covered by the Medicare Advantage plan. Those bills, those kind of hospice bills, are paid for by the federal government through original Medicare. Super, super confusing. So I think what we see is, so theoretically, if somebody really needs end-of-life care for a non-treatable condition, they should be getting that through the Medicare hospice benefit, not through the Medicare Advantage plan. Having said that, some Medicare Advantage plans really would prefer to have the person stay in the plan because they're getting a premium for that person. And they might feel like they can really manage them very effectively. And so they can provide what, basically palliative care. And the service list here does include home-based palliative care. So it doesn't have to be curative. It doesn't have to be curative for it to be covered. So I think that, I think you could see a situation where a Medicare Advantage plan is offering, home-based services to individuals with certain conditions. But if that person has a condition in their end of life, they're at the end of life, they would be able to continue getting that supplemental benefit as long as they weren't in hospice. So I guess let me just say that again, because I think that was a confusing way to say it. I don't think CMS intends for this to prevent somebody who's at the end of life from getting the supplemental services. I think what they intend is that if you have a certain condition, regardless of whether you're at the end of life with that condition or not, the plan has the opportunity to offer you the service. So you could be getting, for example, home-based palliative care for, like, let's say you have cancer, home-based palliative care at the end of life, as long as it's part of a plan of care. A licensed professional can include, a palliative care nurse or a palliative care doctor. That was a long answer. I think some of this is a little bit unclear. I think we'll have to wait and see, sort of how it plays out.
This is Kippy again, and what caregivers do in the home is very different than what the nurses and doctors do that work both with palliative care and hospice. Those right now, Medicare covers palliative care and hospice, home health and hospice, but it doesn't, cover caregivers going in and helping an elder get out of bed or, turn them and clean them as they're passing. So
That's right.
So I'm just curious if Medicare Advantage and this new program would cover that, or if it will just continue to cover the nurses' visits.
Well, so I think the reason why it's hard to give you a good answer is because Medicare Advantage doesn't cover hospice at all. So I think for all practical purposes, unless the Medicare Advantage plan is delivering, I don't know, a hospice-like program and paying for it, which I can't imagine that they're doing. I think what you just described is unlikely to happen in Medicare Advantage, because I think if somebody's truly, truly in hospice, they're going to be in fee-for-service. And that, like you said, that care aide that's doing things that are very different would still not be covered in that situation. It's a really good question, and something that, I think will change over time. I think the federal government is looking at putting hospice back, putting it into Medicare Advantage. So I think when that happens, then there'll be more flexibility to also cover the aides in the home as well.
Great, thank you. Clearly very confusing.
It is
a lot
confusing,
of change.
yeah.
Other questions? We have a few more minutes.
There's a couple questions in the chat box. This is Candace. I wondered if we wanted to address those.
Sure.
So hold on. I think, I was like, all the questions like, where's Anne? We lost her. So the only questions I see in the chat box are somebody is asking if they have access to the slides, and I'm very happy for you all to make the slides accessible after the call.
And I can read off the questions down at the bottom here.
Okay.
So one is, when you say caregiver, do you mean a family caregiver, or do you mean a certified nursing assistant or direct care workers?
So in the context of the supplemental benefits, when I say caregiver, I mean family caregiver.
All right,
so in other words, there are, the insurance companies have the ability to offer as a supplemental service a variety of things to support the family caregiver. So that could include respite care or even home-based, care, personal care.
Mm-hmm. Okay, great, thank you. And then, do these new rules mean that agencies that are non-medical, i.e. strictly personal assistance services, can bill to Medicare Advantage?
Yes.
Great. Okay.
Can I follow up with a question? And would the direct caregiver be being paid directly by the insurance company?
That is how it is supposed to work. Yes. So
And
that's
then,
why. Yeah.
So then there's going to be an incentive for the insurance company to negotiate a rate with the agency or the cooperative that's providing that care. So we could get into a dynamic similar to what we have on the Medicaid side of lower compensation.
I think that's a risk. Yeah, I think it's a risk. Certainly, it's a little bit, it's sort of kind of have to wait and see. I mean, they can't, like with the dental benefits or with other kinds of supplemental benefits, I think because the benefits are relatively minimum, it's not, these are not big, they're not paying for, a lot of services yet. And so I think they're just dipping their toe in, and I don't think that they're thinking too much about what the rates are. But I think that if this becomes a bigger thing and there are more insurance companies doing it and they're paying for more services, I think you would imagine a world in which there would be some rate negotiations.
Thank you.
And could you also just, and also actually Leslie, if you could revisit the slide with the resources. There was a request to restate the website where to find M&A plans, which I believe was the Better Medicare Alliance. But if we could just go back to that slide, that would be helpful.
Yes. The Better Medicare Alliance, it's the middle one. And that's the one that has the list. You may have to flip around on the website a little bit, but if you're looking for a report that's by Milliman, the Milliman actuarial firm. So just scroll around on the website until you find, I think it might be under their reports page tab.
Great, thank you.
We'll post that, the slides as well as the audio on the website.
Perfect, thank you. Okay, any other last questions? Otherwise, we are at time. Well, actually, maybe I'll cut it off because we are at time. So if people do have questions, you can feel free to email them to me at kcasda@icagroup.org or to Anne, who is very generously sharing her email address here and info at. Thank you so much, Anne. This was very, very informative. I think we all learned a lot and gave us a great view into this complicated world, which is forever changing. So we'll have to have you back again when the next updates come online.
I think we'll know more. I think this is going to be, I think it's going to be constantly shifting and moving, and we're all really kind of learning as we go. So I'd be happy to.
Great. Thank you so much. And we will, just to reiterate, definitely put this online. and yes, and make sure that we get the report out. So just a couple of notes from the chat saying thank you and very informative and awesome presentation. So thank you so much, Anne. And thanks everyone for joining today.
Thank
Okay.
you.
Thank you.
Bye.
Bye-bye.
Take care, everyone. Thank you.
you.
Yes, happy holidays.
Same to you.
Same to you.